warm hello from in these challenging days to all of you. And I would like to present the deficiency of ADA2 patients from Turkey in the last couple of years. So what I'll do is I'll start with our experience in Hacettepe University, the pediatric and adult rheumatology clinics. I will review the enzyme activity levels that we tested in these patients, and then I will summarize the other patients from the country. So you all know that these patients can either present with features mimicking polyarteritis nodosa, vasculitic features, skin lesions. Stroke is quite common, and some may present with hematological and immunological abnormalities. Now, we reviewed our experience in the patients in Hacettepe University, pediatricians and adult rheumatologists in this paper. And in this paper, we had 24 patients with DADA2. As controls, we used 89 patients who had mimicking features with DADA2. And actually, 3 of them had classic polyarteritis nodosa, whereas some had other systemic vasculitides, and 5 had Diamond-Blackfan-like anemia. Now, we had 14 with vasculitic features, and we had 9 with hematological features. When we looked at these patients with the vasculitic features, the polyarteritis nodosa-like phenotype, we saw that these patients, the 2 patients, did not have the typical thrombocytosis, the massive thrombocytosis we see in classic PAN. Their thrombocyte counts were usually in the low normal range. And inflammatory attacks were quite evident in this group, whereas they were not so in the hematological group. So here are the characteristics of the adult patients in this series. And as you can see, some of them were diagnosed quite late. They had a variety of neurological features. Only 3 of them had stroke, although their ages were as high as 49 years of age. They had this typical skin features. They had some had hematological findings. 1 had myelofibrosis, and it was interesting that all had proteinuria. So it looks like if the disease is not treated adequately, it does harm the kidney with its inflammation. Actually, 1 had secondary AA amyloidosis. There were GI findings as well. Some had the typical arterial aneurysms of vasculitides. And in the pathological specimens, 1 had amyloidosis in the kidney, 1 had focal segmental glomerulosclerosis, 1 again had a kidney biopsy showing some mesangial sclerosis, and 1 had typical vasculitis in the medium-sized arteries. These were their previous treatments. From then on, they were all switched to anti-TNF treatment. And these were the characteristics of the pediatric patients in this series, the ones with vasculitic features, polyarteritis nodosa-like phenotype. As you can see, the pediatricians were quite aware, and we were diagnosing them quite early. The leading mutation, both in the pediatric group and the adult group, was G47A. And as you can see, they had a variety of neurological findings, such as peripheral neuropathy was quite common. 4 of them had a stroke. The remaining did not. They had all of them had the typical livedo. And 1 had macrophage activation syndrome, which we thought was interesting. This was frank secondary hemophagocytosis. 1 had lymphopenia, and 2 had low IgM levels. As to their GI findings, there was 1 with intestinal perforation. Some had hepatomegaly. And when we looked at the angios, actually 3 of them had very typical aneurysms, either in the hepatic artery or the renal arteries, which we would previously think would be polyarteritis nodosa. And some had biopsies showing either necrotizing vasculitis of medium or small size arteries. 1 had mesangial proliferative glomerulonephritis in the kidney biopsy. Now, when we look at these patients' biopsies, actually, the ones that I reviewed, our pathologist, who is quite experienced, tell me that there is no way she could distinguish the necrotizing vasculitis of DATA 2 patients from classical polyarteritis nodosa. Similarly, when we look at the aneurysms we see in these patients, we wouldn't be able to differentiate them from classical PAN. So another thing that was maybe interesting in our cohort was that stroke was maybe less frequent. We weren't sure if this was due to lack of awareness among the neurologists or it was because of certain genotype specialties. There were some unusual renal involvements in these series. One had focal segmental glomerulosclerosis, one had mesangial proliferative glomerulonephritis, and as I have already alluded to, one had renal amyloidosis. It was interesting that one patient had very severe left ventricular hypertrophy, systolic dysfunction, very severe myocarditis. One developed macrophage activation syndrome, and one had pancreatitis. When we looked at the patients who had hematological and immunological features, they also had some systemic features. 10% only had ischemic stroke. They had some immunological features as well. These patients did not respond to anti-TNF and had to be enrolled to stem cell transplantation treatment. My colleague in hematology tells me that there are certain features that are different in the two patients who present with hematologic findings from Diamond-Blackfan anemia. They present earlier. The anemia is normocytic. The erythrocyte EDA levels are normal, and they don't see the congenital malformations they see in Diamond-Blackfan anemia, but they might have some systemic features, such as I have shown you in the previous slide. For the diagnosis of these patients, of course, the gold standard is to do a mutation testing, which is now called the ADA2 gene. Or you can look at the ADA2 enzyme level testing, and that I would like to review with you our results. As you can see, when we looked at the patients with polyarteritis nodosa-like features, vasculature features, or the ones with hematological features, all of them had non-detectable ADA2 activities. When we looked at the 3 polyarteritis nodosa, classic polyarteritis nodosa patients, they had normal levels, and so did the classic Diamond-Blackfan anemia patients. The heterozygotes, the mothers or fathers of these patients, had levels in between, but they did not have any clinical symptoms. When we looked at our mutation frequency, we thought there was something really standing out, and that was our patients with the vasculitic phenotype had at least one mutation, one G47A mutation, whereas the hematological and immunological phenotypes had various mutations affecting mainly the catalytic domain, not the dimerization domain, like the PAM phenotype patients. So what about the other centers in Turkey? The main adult rheumatology centers gave me an estimate of about 30 adult the 2 patients. This is including the 6 that have been included in the Hacettepe series that I have reviewed with you. Apart from these adult patients, the main pediatric rheumatology centers have about 28 pediatric patients. And these are mainly from the west or east part of the country. From Istanbul, they have 12 patients, and intestinal perforation was present in 2 of them. In another center, hearing loss was present in one of the patients. And as you can see, G47R is again the main mutation in these patients. And these 2 of these groups have already published their experience, and this is the second one with the 5 patients. And 2 of these had hematological features, so they went stem cell transplantation. When we look at the final status in Turkey of the DADA2 patients, Now all are treated, all that who are diagnosed are treated with anti-TNF, or if they have hematological features, stem cell transplantation. As far as we know, there might be more, but we know that there were a total of 5 deaths. 2 were adults from our Hacettepe series, and 1 had died due to very severe necrotizing pneumonia. 3 deaths were reported from Istanbul. 1 was due to intestinal perforation, and the other 2 were due to cerebral bleeding, probably because of hemorrhagic infarcts. So most of our patients look like, in this part of the country, in the Eastern Mediterranean, they are morely polyarteritis nodosa-like patients, the vasculitic patients. And maybe this is because of the high frequency of G47R in the region. Actually, it looks like this was the main mutation, just as the Georgian Jewish population. The patients have other features as well, and especially the adults had some kidney abnormalities. And strokes seem to be less frequent, but we're not sure if this is due to lack of awareness. This might increase. We're not sure if the differences can be explained by mutation only, or there are other epigenetic or geographic factors. Of course, we need collaborations for final answers. So I'll stop there and I'll take your answers while I thank my group, my collaborators in molecular genetics, and of course, our patients. Thank you.